Hello everyone, welcome to the short notes series. So in this video we will take up a topic and discuss it in such a way that you will be able to comfortably write a 5-mark question in your university exam. Today we will discuss about Pseudotumor Cerebri, that is Idiopathic Intracranial Hypertension. Pseudotumor cerebri is also called as Idiopathic Intracranial Hypertension, characterized by raised intracranial pressure without any identifiable mass, infection or hydrocephalus. It mimics the symptoms of brain tumor with normal imaging, hence the term pseudo, that is false, and tumor mass. It primarily affects young obese women of reproductive age group. So the term pseudotumor, that is false tumor, is because the clinical features resemble that of brain tumor such as headache, papilledema and vision loss. However, no structural lesion is found in neuroimaging. The raised pressure is due to CSF circulation imbalance rather than a real tumor. The exact mechanism remains unclear, but proposed mechanisms include impaired CSF absorption at the arachnoid villi. The precipitating factors are obesity, recent weight gain, female gender, especially in the reproductive age group, intake of tetracyclines, vitamin A, corticosteroid withdrawal, and lithium. Endocrine dysfunctions, systemic disorders like chronic renal failure, anemia, and when no secondary condition is identified. Coming to the clinical feature, there will be headache which is diffuse, throbbing and worse in the morning or with coughing. Visual disturbances include transient blurring, double vision due to sixth nerve palsy, progressive visual field loss. Then there will be pulsatile tinnitus resulting in rhythmic whooshing sound in the ears, associated with nausea, vomiting and neck stiffness. These symptoms are usually caused by elevated intracranial pressure. So this is an example of papilledema. So papilledema is the hallmark feature seen in the fundus examination. In case of visual acuity, it will be normal initially where the visual fields show peripheral constriction. Sixth nerve palsy will be there that causes horizontal diplopia. No focal neurological deficit other than visual symptoms. Chronic untreated cases may show optic atrophy. It is diagnosed by modified Dandy criteria, which include symptoms of raised intracranial pressure like headache, tinnitus, visual obstructions or papilledema. Then normal neurological examination with the exception of sixth cranial nerve palsy. Normal brain scan showing raised ICP but no visible mass. Raised lumbar puncture pressure, opening pressure, which is usually greater than 25 centimeter of water with normal cerebrospinal fluid composition, and the patient is awake and alert. So coming to the investigation, an MRI or CT brain reveals normal finding with no space occupying lesion or hydrocephalus. MR venography can be done to exclude any venous sinus thrombosis. Lumbar puncture of raised CSF opening pressure with a normal biochemical composition. In ophthalmology, visual field testing, fundus photography to monitor papilledema. Diagnosis is usually confirmed by elevated CSF pressure with normal imaging. So this is the normal MRI with no obvious space occupying lesions that is seen. Coming to the management, this involves weight loss and low salt diet. Medical therapy include acetazolamide is the first line of drug to reduce the intracranial pressure. Furosemide is an adjuvant and short-term corticosteroids in severe cases. Surgical management is required in emergency or severe pain, wherein optic nerve sheath fenestration is done to preserve vision, or CSF shunting like a lumboperitoneal or ventriculoperitoneal for refractory cases. Regular ophthalmic monitoring is essential. So coming to the prognosis, it is generally good with early recognition and treatment. Untreated or delayed cases may lead to permanent optic atrophy and blindness. The key points include raised ICP without tumor or infection, common in obese women. Papilledema is hallmark, and hope you should be now able to write a 5-mark question with this presentation. Thank you.